Hello, and thank you so much for joining us today for the webinar Gain Time by Periodontal Treatment. It is a great pleasure to introduce to you Dr. Carsten Stockleben, whose aim during this presentation will be to discuss about the advantages and disadvantages of tooth preservation and implantation from the medical side. We would like to thank Dr. Stockleben for being with us today and KaVo for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Stockleben at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Carsten Stockleben.
Hello everybody out there in the internet. A warm welcome from sunny Hanover, Germany. We're gonna spend 1 hour together on my favorite topic, that's prophylaxis and perio, and we're going to discuss a certain aspect today. It's the question, when does it make sense to extract a tooth to make room for an implant? Of course, there are different perspectives that we can choose to look at it, and I'd like to share my experience on this topic of preserving teeth versus implantology. Okay, let's get started. Well, what are the topics today? One is psychology, because in my mind, health starts in our head, in our thinking. This is the first step up here, whether it's about treatment protocols, treatment planning, success, or whatever. It's always the first step in our mind. And this is true for the doctor as well as the patient. Then we're going to talk about diagnostics, because this usually is the first step when it comes to treatment planning and decision making. And decision making also is a point when we talk about preserving teeth versus extraction, and maybe as one treatment option, choosing an implant. So what's important in decision making? And of course, if you want to preserve teeth and soft and bone structures, well, we've got to talk about prophylaxis and perio concepts. And that's teamwork between our employees, patient, and ourselves, the doctors. And in the end, there are no free meal tickets. What does it cost? What do we charge? Or do we charge at all? Or do we want to save the world? So economics is another aspect. Okay, let's go to psychology. A couple of weeks ago, I was discussing some philosophical question with a patient, because in this discussion I said, well, the problem is patients come to our offices and say, please doctor, help me to get rid of my symptoms. But basically, to be true, when we look at disease and dentistry and most other medical fields, there's a lot of psychosomatics. Usually the problem is that the patient comes and says, please help me to get rid of my symptoms, but do not change my lifestyle, which usually leads to these problems, because things are not in a balance. And this disbalance starts in the way people think about themselves, their life, their lifestyles, etc. So it comes from the psychological level to the behavioral level to the metabolic level. So if you look at a muscle that's tense, for example, when we look at CMD, of course, there can be a mechanical problem or a mechanical problem in conjunction, but usually there's a lot of psychological disbalance in the patient. But this pattern, in my eyes, is valid for many aspects in our offices and also in our personal lives. So when we talk about ourselves and we want to preserve teeth we've got to have preventive thinking or preventive attitude. And this then will influence our office concept, how we behave towards our patients, how we approach him, to get him to show compliance and behavioral change. And in the end, this is part of therapy, and this preventive thinking also influences our kind of therapy that we choose. When we talk about the patient, well, it's healthy thinking. In the last years, I've seen many patients in my office who've got this fashionable problem called burnout. And in younger days, I never thought that I would have to do or to deal so much with psychosomatics and psychology with my patients. But if I want to be successful with my patient in whatever kind of treatment, I have to have a further look into his mind, into his psychological patterns. And often our thinking is negative. If you look at the news, only bad news or good news, etc. So you've got to have a certain mindset to have a healthy way of thinking, positive, which basically everybody knows. But it's easy to come off track. And then a more negative way of thinking starts and develops, and this might be the new comfort zone, and it's difficult sometimes to leave this comfort zone. So a positive attitude and behavior are imperative for a balance in life. And if you've got that, you're going to take care of yourself, because here as well, positive thinking will give you a more healthy body and healthy lifestyle. But of course, there's a lot of business about that, so it's easier to take pharmaceuticals and make money on that aspect instead of changing your lifestyle. So when it comes to lifestyle, periodontal disease, in my eyes, has a lot to do with healthy behavior or unhealthy behavior. And it comes to a very simple thing. Do you take care of your biofilm? Do you clean properly? Have you learned how to clean properly? And are you being taken care of in a prophylaxis or recall system that's risk-oriented for your case? But we've got this problem of periodontitis, and the problem is the quality of the biofilm, which you can see here on the left-hand side of the screen. And if you've got a grown and well-developed biofilm in the, let's say, proximal area or close to the gingival margin, or even if you've got developed pocketing, well, what's going to happen? Because there will be an immune response. And if you look at the common model for periodontal etiology from 1997 from Page and Kornman, there will be a reaction in the soft tissue and later on in the hard tissue. But we've got antigens and virulence factors, and the response of the body, of the immune system, will be the development of antibodies and neutrophils, which means we've got an inflammation. This is what the patient might notice by bleeding gums, and we see if we take a periodontal index and look at it. So inflammation takes place, and inflammation, of course, leads to more destruction by the development of cytokines and metalloproteinases, and they influence the connective tissue, the metabolism of the bone and of the collagen. And of course, we've got risk factors that influence the kind of reaction and the severity of disease development. So external factors, for example, are smoking, bone diseases, stress, because, well, we're living in a stressful environment and society, and stress reduces the immune response. Obesity, which is a big problem in the civilized world, also is a risk factor, and very interesting, very complex how these two things go together, periodontitis and diabetes mellitus. Then, of course, we've got inherent risk factors like interleukin 1 beta genotype or the immunoglobulin 2 antibodies. But of course, after the enthusiasm we've had in about 2000, 2002 about getting to know and laying out the DNA, we thought, okay, this is the answer to all the problems we've got. We had to realize that this is, let's say, the hardware, and we're now discovering the software, which is called epigenetics. So how do we respond, or how is the cell response in the short term and medium term, which influences the response of the DNA? Highly interesting topic. Okay, but what's going to happen with the change in the connective tissue? And this is the speed of disease development is influenced by external, internal factors, is as an outcome the clinical disease. We're going to see inflammation, we're going to see bone destruction. So this is what makes periodontitis. And of course, the better location or in the pocket helps the development of a more pathological microflora or biofilm. So this is a self-running system if we do not interrupt the development of the biofilm, or I call periodontal treatment also biofilm management, because basically this is what it's all about. Okay, so this is the way we look at periodontal disease. But in the end, if the biofilm on the left-hand side, the microflora, is okay, there are no or few pathogens in the spectrum, then we're on the safe side. If there are lots and mean bugs, then we're going to have problems influenced by the internal and external factors. So behavior, as I said, is the key point. The key point to get to this stage, to develop periodontal disease, and also to change the health status or the disease status. So if we look at periodontal disease and time, there's a change on how to look at our indexes. Because in younger patients, so up to 40, 45, we usually don't see a lot of recession. So pocket depth and loss of attachment is basically identical. This changes in the middle of the life because then usually the soft tissue, the gingia, will follow the bone. So we're going to see recession. But to have a clear view on how severe the situation is periodontally, we have to look at attachment loss, which is defined by the pocket, by the bottom of the pocket, and the enamel cemento junction, which can differ, sometimes a lot, from pocketing. So this is important to know, and we've got these big studies in Germany. The next one is prepared for this year now with lots of thousands of participants. And if we look at the definition of periodontal disease scientifically, we've got an attachment loss 1 and 2 millimeters as light periodontal disease, and 3 to 4 as medium, and 5 millimeters and more as severe periodontal disease. And if we look at the age group of 35 to 44, the middle agers, well, 62% show severe periodontal destruction, but mainly localized, which means that not all 4 bony walls of a tooth have got the same problem, that you might only have a 5 millimeter pocket or attachment loss in one bony side. So let's say at the buccal or in the proximal. This changes with time because when people are getting older, so if you look at the age group that's about 20 years older, 65 to 74, we've got about 90% with severe periodontal signs. And here we've got more than 50% with a generalized pocketing. So that's more warts around one tooth, but also multiple teeth that show the problem. So it's interesting to see that while we're waiting, a friend of mine in England calls this supervised neglect, because people attend the dentist and might even take part in a recall system, in prophylaxis, and they even develop periodontal disease, which is fatal psychologically as well, because it undermines the trust that patients have in what we do. But we're going to talk about this at another point. So what's going to happen is if we look at demography worldwide, if we look at 2012 and dark red down here, it says that in a country there's a population, an elderly population over 60, which represents 30% of the population or more. And if you look at here, Germany and Scandinavia, well, we've got a problem. Japan as well, and Canada is getting older as well, while other countries are much better off, especially Africa and Asia. But if we look at the prognosis of 2050, there's a lot of dark red in North America, Russia, completely in Europe, Australia, parts of Asia, China, with an overaged population. And this is very new in mankind, because usually we've got a broad base of young people and a small peak of elderly people. So we've got this typical pyramid that I'm going to show to you. And here you can see the German pyramid in 1910. We've got a broad base of young people and a small peak of elderly people, about 60, 65 and older. But what we're going to see now, this is in 1999, we've got a small base of young people. Of course, you can see world wars have shown their effect here with the loss of many lives. And then we're going to see here the belly. These are the baby boomers. But there's not a lot to follow. And if you look at the prognosis of 2050, we've got quite a lot of old people which are on a broad base and also getting older as the ones 140 years ago. And of course, if you look at the base of society, young people, there's a big difference. So there are only few young people coming up, and this is a challenge for our societies. This will be very interesting that's coming up. Okay, what does it mean for dentistry and for periodontal disease, to cut a long story short? Well, as you can see here, in comparison to here, where usually people didn't have teeth, here usually they do have teeth, maybe not completely, but partially. And here, they're going to have teeth, they're going to get older, and there are lots of them. So, periodontal disease is the challenge. Not only for our health systems, but also for the dental community. And if you look at German numbers, these are a few years old. In the age group of 35 to 74 years, we've got, we guess, about 23 million patients who have moderate or severe periodontal disease. And in our state-run health system, every year we do about 800,000 periodontal treatments. We would need many more to show some effect. So what we are looking for now in our new study for this year, that we're going to have worse numbers for periodontal disease. It will be on the increase because of these effects. And dentistry has just the topic or the purpose of looking at caries, and this is the wrong perspective in my eyes. And if you look at periodontal diseases and the systemic link, what's happening in our system, because it's a chronic disease, and of course all the time, 24 hours, 365 days a year, you've got pathogenic microbes, toxins, interleukins, and whatever our body produces in its immune system. And of course, this causes great damage in our system. I think losing teeth is bad, but the systemic link is a nightmare. Periodontal disease is a silent killer. So we're discussing low birth weight, premature birth, chronic respiratory diseases, especially if people are hospitalized in the ICU units and are on the lung machines. Diabetes mellitus is a two-way relationship because people with diabetes will develop faster and a more severe form of periodontal disease. On the other hand, if you've got somebody who has got severe periodontal disease, he is more likely to develop diabetes mellitus. Interesting. You basically die earlier, you lose up to 6 years statistically in your life. Osteoporosis is something we're discussing. Atherosclerosis, of course, because of the pathogens in the blood that will cause damage in the arteria and in the intima. So coronary heart disease, stroke are increasing. We're talking about a link to the rheumatoid arthritis, and of course erectile dysfunction in men, which makes sense because of the changes in the arteries. There are highly interesting studies out there with cognitive decline in conjunction with periodontal disease, and we're discussing the development of carcinomas. So it's a very, very bad disease, and it's time to act and to do something. Well, what does it mean if you've got a severe periodontal patient? The surface of the inflammation is about as big as the palm of my hand. So you've got lots of bacteria, viruses and fungi, and the inflammation will stay over decades and progress, and there's no cure, there's no way back, no reverse gear, and the inflammation, of course, can be controlled, and this is what we do. So best way to prevent periodontitis is to get a patient early enough before he develops the typical signs of bone loss. And then it's quite easy to keep him stable. Does it work? Yes, of course. And we know this for a long time because Axelson, for example, showed this in '87. After 15 years of prophylaxis in his patient group, he could show that people who would be taken care of, risk-oriented, would be stable in their bone level or even show a little increase of 0.2 millimeters. While if you don't take part in such a program and just visit your dentist and clean, as usual, then you're going to lose about 1.4 millimeters of attachment in 15 years. So that's about 0.1 millimeter per year. So there's a clear evidence and we know the answer, what to do, so why don't we do it? And Axelson, who is or was very engaged in prophylaxis, could show after 30 years in his group that the incidence of caries and periodontal disease, as well as tooth mortality, was very small. And I've been doing this long enough now. I'm involved in prophylaxis and perio in more than 30 years now. But when I was young, I thought, well, they can do this in Sweden and at university. No, we can do it. Everybody of you can do it in your office. I wouldn't say it's easy. It takes a lot of effort, of course. But it's worthwhile because it's giving us an environment that makes dental work fun and stable. So it works. So if we look at diagnostics, well, it's the mother of therapy. This is what we say in German. And it's crucial. We've got to know the problem and we've got to know what to do. So diagnostics is important to have a sound diagnosis and to evaluate the case, whether it's a periodontal case or not. Managing the disease, therapy, the blue part here, is a lot of prophylaxis and, of course, active periodontal therapy. But that has changed over the years. I've learned to do these big flaps and resective surgery, and which was really mean and brutal. It was just amputation of tissue. And if we didn't have a sound prophylaxis system, it will go down the drain anyway, with or without surgery. So we have to have concepts and an understanding of what to do. And nowadays we're talking about minimal invasive approaches. So this is modern and future therapy. So what do we need? Bleeding and probing, attachment loss, pocket depth, mobility, we need x-rays, and of course what we use in our office, we've got a score for compliance. Because if the patient don't comply well, you won't have a winning case. It makes it very difficult to win the battle. Okay, and of course this lecture is sponsored by KaVo, and I've got a long working relationship with the company, and of course I'm happy to introduce some of the toys that they've got. For example, an instrument I like for diagnostics and in patient education is the Diagnant Paro, which is great for patient motivation. We use it in recall and for diagnosis. You can detect caries on the surface, but with a sapphire tip, which is unfortunately very fragile and expensive. But if you go into the pocket, as you can see in the picture below, you can detect complements. And that's great, because it can tell, without opening a flap, whether you've done a good job or not. So you can check what you've done, and if you've got recurrent problems, you can check, because if there's biofilm, and especially concrement, then it will start problems again. It's pain-free, and it shows numbers and an acoustic signal. So the patient and you know what's going on. And of course, we've got different levels in diagnostics. First, of course, it's the clinical approach. Then you go to X-ray, which is panoramic X-ray. And for many years, when this technology started to enter the market, I love the CBCT. If I've got a severe periodontal patient, I like to take a CBCT instead of panoramic X-ray, because three-dimensionally I've got a much better view of the problem, and my evaluation for every tooth is much better. So I can look at bony destruction, at furcations, I can plan surgical excesses, and of course prognosis will be very different. So if you look at this case, for example, patient very frightened, of course, male, he used a lot of chlorhexidine and regularly attended the recall. Unfortunately, he passed away in the meantime, but we could preserve this situation here, the canine and this molar, and they are both highly damaged for 15 years easily, because he showed good compliance, the quality of the program fitted to the situation, so we could easily keep these teeth in. There was no need for implants. And in this case, for example, and this might have been one reason for his good compliance, he was so frightened of surgery and implants, and I would have loved to close this gap with implants, and money wasn't the problem, but fear was in the way. So that motivated him so much to do his utmost to preserve these teeth. And this is a case, there is bone here which is so thin in these pockets. It's a severe periodontal case where I needed to do augmentive surgery. The bone layer is so thin, it's thinner than the slices of the CBCT. So it was highly interesting to plan the surgery. And even though this is a smoker, this patient shows fairly good compliance, and I did the surgery a couple of years ago. And so far it all went successfully. We could reduce the pocketing about 2/3, which is great, and it runs stable. The problem with two-dimensional X-rays is that we've got our film in the mouth, we've got the X-ray beam, and we've got a three-dimensional tooth. And this is projected on a two-dimensional surface. So what do we see? We've got severe problems in the trifurcation. Do we see this here? No, we don't, because of the superimposition of other parts of the tooth. So, if you look at the same patient in a panoramic view, we see the second molar on the right hand side severely damaged. The other side doesn't look too bad. What I've learned is life is symmetrical. So if I've got a problem here, I should always look on the opposing side. So what did we find? Well, three-dimensionally it looks good. The buccal plate seems to be okay. No idea of problems. But if we look at the slice here, you can see severe damage of the trifurcation, and that tooth was lost in the end. Or for example, clinically, this bifurcation, grade 3, was very difficult to diagnose, but in the CBCT, it was very clear to see that there's a problem here. And of course, we can address it and keep this tooth for a long time. if the patient cleans it after surgical access and an opening for cleaning. And sometimes we find funny things like this periodontal complex in the X-ray. My brother is a specialist for endodontics, and he did this endo, so it looks quite good. But it didn't work after a couple of years, so we had to look at it. And what was the problem? Well, you might know this. There was a small fracture line down here in the mesial root, and so you cannot save this tooth anymore, and it was replaced by an implant. Okay, so preserving teeth versus implantology. Sometimes we cannot save teeth. It's the crown is in total destruction, or you cannot just do a root canal because the crown is broken down so badly. Or you've got fractures in the root, or fractures in the crown that go so deeply that it even becomes surgically difficult to preserve a tooth, even with crown lengthening. So, what's important? Well, basic indicators for tooth loss: probing depth, furcation, mobility, bone loss, and don't forget, function. Parafunctional habits, especially when people don't wear a bite guard. Terrible. In conjunction with perio, it's a nightmare because the speed of destruction is much faster. And of course, smoking is a very bad risk factor. So if we look at prognosis, we've got to ask, well, what parameter, or how many parameters do we take? And in scientific research, for example, in this McGuire and Nunn study, these were the parameters, but you gain a lot of data. So people asked in the Trombelli group, well, can we do it easier and reduce the number of data or the amount of data to get a good questionable or hopeless prognosis? And they could show that bone loss and or furcation involvement are quite reliable signs or predictors for risks or tooth loss. Tooth loss is the endpoint in these studies. It's a very secure endpoint because there's no discussion. It's either in or out. And hopeless meant 70% bone loss or 50 to 70% plus furcation involvement. And of course, molars are much more in danger because of the more complex anatomy of the root system. And another study, which is quite old, from 81, from Axelsson and Linde, so classics, they both stated that the maintenance is paramount or of paramount importance. So recall frequency is the key to success, and I can only agree on this. Okay, then sometimes we've got the problem that we've got neighboring teeth that have got big periodontal problems, a lot of bone loss, and the neighboring tooth might be okay, or the implant. So what does this mean? If you don't do anything, the prognosis is no good. But if the patient is integrated in a prophylaxis system, it's a question of maintenance frequency, whether you're able to keep the situation stable. Because, of course, you've got a very active and aggressive biofilm, and the biofilm is always on the move. So it will, of course, attack the implant neighboring to the side or the tooth, and other ones as well. And, of course, if you start kissing and so on with your partner, you share this biofilm as well. So the first look should always be the quality of the biofilm in the mouth. That's as a more private advice. So what is important? Ethics. As a dentist, you've got some freedom of choice. And it depends on your personal ethics whether you like to keep a tooth or not. Some people might have the opinion that every healthy tooth is an obstacle for an implant. Well, that is a perspective, it's not mine. But we've got to discuss tooth preservance versus bone preservance. We've got to look at the periodontal risks, at the compliance of the patient. If the patient doesn't comply, well, it's easier and better to extract teeth earlier, I think. It's a question of the quality of the biofilm management, whether your system works efficiently or not, and of course function is an increasing problem because of the function load on the periodont. And this is a case that I would like to share with you. It's a patient born in '53. It's a female patient. She came into our office in October '05, showed a fistula at 1.1 and 1.3, so central incisor and canine. There were 7 active pockets showing pus, pocket depth with up to 12 millimeters, and bleeding and probing was 100% as a starting point. Her home care was above average. Teeth are important for her job, so guess she's a teacher, and that can be difficult, and she's highly concerned about her teeth. So this is what it looks like. You can see here a big problem in the canine, and of course she's got a dental history. She regularly attended a dentist. She had 3 quite large surgical perio treatments in the last 12 years. No professional maintenance, so it was a failure. Easy to guess. So after an intensive treatment interval, I saw her in December 2005 for reevaluation after phase 1, and my brother did a root canal, so the fistula disappeared. Bleeding or probing was 0%, with mobility 1 on 3 teeth, and with an average of 3 millimeters probing depth. Maximum was 6. So that was quite a successful start. So what was the treatment regime? We had 7 prophylaxis appointments. We did a full mouth treatment with a minimal invasive perio approach, so no surgery. We used antibiotics. In those days it was amoxicillin and metronidazole, but nowadays I'm much more careful about using metronidazole because it's a very tough and hard antibiotic. We didn't use any local anesthetics for the perio treatment, by the way. We integrated her into the periodontal maintenance program with 6 weeks intervals. Nowadays she's in 3 month intervals. She is very reliable, and she was enthusiastic. She still is. Compliance is great. It's a 1. So we started planning for treatment phase number 2, where we, because the front was doomed for extraction, and since she was so frightened, we actually extracted the front, I think, in 2013 or 14, and did bone grafting and implants in the front. So we kept these teeth for another 6 to 7 years easily. So this is before and after. You can see the reaction of the gingiva and the reduction of the swelling, which explains the huge decrease in pocketing. And then you can see here the root of this second molar. We kept this for years, by the way. It was unbelievable. My brother had to do a root canal, but then the tooth was stable and not mobile. Was great. So this is before and after, and you can see how thankful the soft tissue reacts if we take care of the biofilm. So it's teamwork to do prophylaxis and perio treatment. So what I wanted to say, by the way, is it's always a very individual decision. And scientifically, we don't have a real agreement on when to extract a tooth. So it's basically in our hands, and depends on how good the patient complies, how good our system works, how we manage the function, because we see more and more people bruxing, so psychosomatics is quite a challenge. And so to find the proper point when to extract a tooth and maybe insert an implant is very individual. So knowing these different approaches and which data to look at, I think is very important. So if we look at the quality and the challenge in prophylaxis, it's of course, we've got a lot of documentation and diagnostics here on the left-hand side. We've got a lot of psychology when it comes to motivation, compliance, and instruction. And of course, we need a lot of equipment in our offices and good, profound knowledge about what to give in the patient's hand for home care, because things should be, well, I like this KISS system, keep it simple, stupid. Sometimes less is more, because I'm happy when people comply to a certain degree. This is much better than good knowledge and not doing anything at home, because it's too complex. But if we look at prophylaxis and what our employees have to do, it's quite challenging, because usually we look at caries, but that's boring, and it's yesterday's dentistry. Nowadays it's also looking at periodontal disease, looking at bruxism function, looking at erosions, so nutrition. So and this is all something, you know, it's here in our head, it's behavior, it's thinking. Halitosis is a topic, and then of course soft tissue alterations. If you look at Lichen-Ruber or the development of our carcinoma. So prophylaxis is a complex business. So if we look at risk orientation, we've got light, moderate, and severe perio cases. We, in our office, have different approaches. All patients attend an introductory program, 3 visits with a break of a week in between. So every visit takes about 45 minutes to 60 minutes, depending on the problems and its compliance and understanding, etc. Where I get all the data for risk assessment. And then, of course, we've got the periodontal treatment, which is very conservative in the light cases, which is conservative. But with more emphasis on clean pro powder and full mouth treatment in moderate and severe cases. And the more severe the pocketing becomes, the greater the challenge. And we use photoactive disinfection, full mouth treatment, sometimes antibiotics. But as I said, I'm more careful about this now. The moderate and always the severe cases are gonna take part in a post-perio program, because we've got 4 weeks for the healing of the gingiva, of the soft tissue. And in this period of time, these 28 days, we like to have a clean pocket, clean oral cavity. So we're going to see the patients every week for half an hour to clean the pockets and the whole system, and they get full mouth treatment. Also, chlorhexidine, cleaning of the soft tissues, and at home, and the tongue, etc. So we do as much as possible. And then, depending on the risk, we're going to see them in the recall 12 weeks or sometimes 4 to 6 weeks. So this is a very individual and risk-oriented decision. And afterwards, we're going to go into reevaluation and then into, if it's necessary, into a prosthodontic treatment phase. So when we talk about recall, we've got patient coming in with disease. We do our introductory program to keep his health up, to get into a safe harbor here, and to keep him with a recall in this safe stage. And if he doesn't show compliance, well, we get a recurrence of the disease, which is very natural because of the growth of the biofilms. And well, recall intervals in our office are 3 months for normal peri patients, 2 months for high caries risk, and sometimes high risk peri patients and severe peri patients are going to have 1 to 2 months. The length of the treatment is 20 to 60 minutes, depending on the situation. So that's always a very individual decision. And of course, if you look at the American Academy of Periodontology, the recommendation is people with history of periodontitis, 3 month intervals or shorter, so very individual. And of course, we shouldn't forget this, should be returned to active treatment if there's a recurrence, or if we see that there can be more progress or success achieved. Another thing which is very important is the quality of the recall of the professional tooth cleaning. Only supragingival plaque control fails to prevent further periodontal tissue destruction. We know this for nearly 20 years now, because Ms. Westfeld made these great studies showing that if you do not clean the pockets when the patient is in for recall, the periodontal destruction will proceed. It's unstoppable. You can stop it, yes, as we see in the control group here, if you regularly remove the biofilm out of the pocket. So this is one of the key messages today, if we want to achieve longevity in what we do. So basically, it's always a question of biofilm management. If a patient comes in, he's got a lot of biofilm here, quantity, and we've got disease, because quality shows that there are lots of pathogenic microbes. When we do prophylaxis, we lower the quantity, the number of bacteria, and also change the spectrum to more healthy species. So this is where we're going to get stability. But of course, we've got the dynamic of life and also of the biofilms, and they're going to double every 20 minutes, so it explodes and will go back to the old stage. This is the reason why we've got recall and risk orientation. So efficient prophylaxis, we've got, for example, and I like these KaVo products, the Sonic Flex scaler, because it fits to the unit. You don't need any new machines. It's quite inexpensive, and it's got all the tools, the inserts that you need for a good prophylaxis cleaning. And it's got a small learning curve. And you've got the Prophyflex air scaler, not air scaler, airflow device. It's an airflow handy, it's mobile, so you can interchange it in between rooms, and it's very reliable technically. You use this either sodium bicarbonate for enamel or glycine for subgingival cleaning, and that's a great tool because it reduces the number of bacteria in the pocket by 99%. So this is modern prophylaxis, and you just have to change a small part here in the powder chamber, and then you can use the glycine or Clean Pro powder, which is great, as you can see here. And you've got also a device to go into the pocket with a kind of needle. And it's great for cleaning implants because you don't have to touch the implant surface with metal. It's very efficient. Or if you look at caries, for example, if you look at the Diagnostics for caries diagnostics, you don't have any x-rays, it's laser fluorescence, and it's very predictable, and it's very impressive for the patient as well. So it's patient education and earlier and better reliable diagnostics. So you get what you pay for, economics. Well, you always have to know your numbers, because it's always individual calculation for your office, depending on your location, or your rent, on the costs for your staff and equipment, etc. So you've got to define a realistic fee per hour, and you shouldn't get inflation every year. For example, well, in Germany we cannot do this because we've got a state-organized system, and that's bad. You'll be laughing now, but I'm working for 29 years and I didn't see an increase in fees. And you must think, well, we're stupid in Germany for many reasons, and sometimes I guess you're right. But this is the way our system runs, unfortunately. Okay, the take-home message is periodontitis is a silent killer, and we diagnose it too late. So please, dear colleagues, take your periodontal probe, look at the tissue. That's imperative. And we've got to have reliable data for sound decision making. Otherwise, you're never on the safe side, and you don't know what you're doing, basically. And you have to have concepts, because they give security and make your life enjoyable. Because you know when you put a patient into a certain protocol and concept that you're going to get a certain result. And that's great. Then you know how to approach the patient, and that you don't have to talk about sometimes we're successful and sometimes not. But in those cases, you're always successful. Okay, and then you've got airflow and sonic instruments by KaVo, for example, that allow gentle and efficient prophylaxis. Because why should we work with our hands and bones and muscles with hand instruments if we've got machines? Everybody else does it. Why should we stick to hand instruments in dentistry when we've got machines and machine-run instruments that are doing an equal or better job without putting so much strain on ourselves? So, I had to hurry a little bit, but it's 57, it's close to an hour. So for now, thank you very much for your kind attention. I hope my English warmed up a little bit because I just came out of the office and sat down by the computer. I hope I could make my point and give you some motivation and hopefully some new perspectives. And now I'm happy to answer your questions, because this window now opens, and if you've got a question, please let me know. Okay. Thank you. I've got a nice compliment here from Americo. Dear Americo, thank you very much. I'm sorry about the sound. We tested it, and it seemed to work. I'm very sorry about that. Maybe it was because I speeded up talking because I wanted to share so much with you. And you'd like to know when the recording is available. I think the Dental Tribune Study Club will be able to tell you and give you the answer. Okay, my friends, any more questions? Oh yeah, from Marina. It's a pleasure. So you're always so kind. What's your opinion about chlorhexidine for home care in perio patients? Great question, Marina. It's a great pharmaceutical because it hardly shows any is it called in English resistance? I guess it must be resistance. Some bugs get accustomed to it actually, so it doesn't work too well anymore after a certain time, because we always thought, or I was taught, that it would be perfect and would work all the time. Well, it's not as easy as that, because the biofilm adapts a little bit to it. But we like to use it because, well, for full mouth cleaning. So as a mouth rinse, as a gel on the toothbrush to clean not only the tooth after severe perio treatment, but also the soft tissue and the tongue. And we like to install the gel in the pocket. And we sometimes teach the patient to use a syringe that we provide and a very small, like periodontal or endodontic blunt tip to install the gel into the pockets to help with the biofilm management at home. I hope this answers your question. Okay, now here's a message from the webinar support. And the recording. Okay, you're going to get an information when the webinar will be posted. From Valentin. Okay. Whether I use the diode laser or PAD. Well, I've played many years ago with diode lasers, but I'm not a fan of lasers. They are nice to impress patients, but I don't like to put harm on the tissue. Because if you get rid of the biofilm and the cochramins, well, the inflamed tissue and the collagen inside start to regenerate. So we've got great chances, or good chances, to have a good healing. My experience is that the less trauma we impose on the soft tissue, the better the healing will be. It's, in my eyes, it's just common sense. But I love to use photoactivated disinfection. So after cleaning the pocket, and it doesn't bleed too badly, we install the fluid and then use a tip, periodontal tip on the PAD to activate it. And that really works well, especially in conjunction with Clean Pro powder. Both systems reduce 99% of the biofilm in the pocket. So if you combine it, you've got great disinfection. Also, if you go into surgery for Periodontitis, for example. Okay, more questions coming up. Sulafa asks, okay, could you state the factors that may determine when to save or extract a tooth? Well, this was this one slide that I showed. You have to have certain data. Mobility is very important. Attachment loss is very important, because sometimes you've got attachment loss. You have got mobility, but you don't have attachment loss. Then you've got to be careful, because what's happening? Usually it's bruxism. And I've seen a couple of patients now that came from implant specialists for a second opinion. And those specialists wanted to extract quite a number of teeth because they were mobile. But when I had a clinical check and I thought, well, I have big pocketing here, I was quite astounded that they showed 2-3 millimeters pocketing. I thought, well, something is wrong here. And if you look at the function, then you can see overload in certain teeth or groups of teeth. Then you go for splinting, either a fixed splinting or a night guard, to change this. And then it's easy to preserve these teeth, for example. I would never take them out. And my experience is quite good. But you have to have functional treatment plus a little bit of perio. But when do I extract teeth? For my personal understanding, compliance is crucial. The quality of my program has to be adequate. So cleaning off the pocket with every visit in the recall. And sometimes I've seen that we can keep even mobile teeth for years. So mobility 1 and 2. And if the patient works well with us, it's amazing how much time we gain. In the end, it's the question, how much teeth, how much bone do we want to preserve? And if I know this tooth basically is hopeless, then sometimes I go for earlier extraction. But then I have to have furcations, mobility, depocketing. Otherwise, I know when the patient shows good compliance and it all works well, we've got years. It's amazing, really years of stability. And if you do a little augmentation, if there should be an implant necessary later on, that's okay. So, Ting, what's the concentration of chlorhexidine mouth rinse? Okay, for home care, it's 0.2%, which is usually readily available in the drugstore, and it's the same concentration for the gel as well. All right, folks. If there, there's more coming up. I hope my pronunciation of your names is all right. Mari, oh, my computer starts sleeping. Mari. Ooh, interesting question. Can hormone inhalation in asthma patients be a risk factor for bone loss in anterior region? Interesting question. Actually, I'm not pretty sure. I cannot remember of having seen this or having heard about this from colleagues in lectures. It might be, but I'm not pretty sure. I'm sorry. I cannot give a proper and I think scientifically correct answer to that. Okay, Sally. So where in the world are you all? It's highly interesting to sit at home at your computer and be connected to all of you out there. I'm sorry I cannot see you. So, thank you for a great webinar. Okay, please continue. Yes, I'll do. If I get invited, of course, I'm happy to share my knowledge. Could you give us some information about splints next time? Yes, of course. It's a great question. It's such an interesting and quite sophisticated topic. Bruxism, and it's much more than dentistry, because dentistry usually is caries, is working on crowns. Periodontology is more, it's bone, it's soft tissue, it's roots. But bruxism is the whole body, it's psychology, and but you've got to take time and show empathy for your patients, because sometimes you get answers only slowly. Sometimes it's a word or a sentence in a conversation where I think, oh, there's a problem, because they won't tell us everything, because they think we're just dentists. We are localized here in the mouth. But splints and diagnosing bruxism and dealing with it is, it's my hobby. It's fantastic. Yes, I'm happy to do so if I get an invitation for another webinar. Okay, I think we've got it. So we're going to go to an outro now. Thank you very much.
Thank you very much, Dr. Stockleben, for sharing your lecture and your insightful information with us. We would also like to thank KaVo for making this online course possible and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your 88 SERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Stockleben may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Stockleben will be sure to get back to you as soon as possible. Please be sure to visit the KaVo educational platform www.kavoacademy.de and keep an eye out for our growing schedule of online courses. Thank you again to all, take care, and goodbye.